So it gives me great pleasure to introduce Gillian Harvey. She's an associate professor at University of Alberta in Canada, and she's co-director of the Design Health Research Innovation Lab, board member of IIID, and she's her research is about information design, which is why she's speaking to us today. So without any more, just to say, yeah, please use chat if you've got any questions. Gillian has also said that she's perfectly happy to be interrupted with questions if you want clarification as she talks. I'll have a look out for hands in the air. Otherwise, we will have quite a long question session at the end of Gillian's talk. So over to you, Gillian.
Hey, thank you. Can you hear me? Everyone can hear me? Okay, good. Good. Okay, so thank you for the introduction, and thank you for inviting me to speak. I have not spoken about this project yet. It is my work and research work prioritizes information design and often designed for decision making in critical or emergency situations. This one is a little bit different, but still includes some of the work that I've done, which includes sort of technical administration for emergency overdose, patient safety, education materials, and pediatric resuscitation. So my work tends to be a little bit more in the health field in terms of a little more technical. I worked with government, industry, and private sector developing materials that include projects that address system concerns and enhance broader healthcare processes. So this is one of them. I'm going to talk about two projects in which design methods, specifically co-design, were used to engage communities with lived experience using non-traditional knowledge forms and community-based decisions in the development and implementation of this solution. So I'll talk about what I think worked well, and then what I think also could be improved using co-design as a research method. And in this project, I should also mention that I'll have to speak about the project in the context of the pandemic. So many of the methods that we used or that we originally conceived of were modified to be remote versus in person. Okay, so I'm trying to change my slide and it's not changing. Oh, there we go. Just have to click. Okay, so this was quite a large project. These are the partners and collaborators. And in terms of the project collaborators on the grant, there were about 19, and they were all of the entire project was funded by grants from regional healthcare institutions and authorities such as Alberta Health Services, which is a health authority within the province of Alberta in Canada. It also included small and mid-sized municipalities, the City of Red Deer, City of Edmonton, City of Calgary. It included local community groups and public libraries, harm reduction education organizations, and anyone, I guess, who felt remotely touched by this issue. So originally conceived, this project was designed to address the need for education and training related to overdose education. So that has been my background for the last few years. But I'm going to talk specifically about the exhibition that was a result of the work that we did, which was designed to be an interactive exhibit rooted in the stories of lived experience around substance use disorder. So originally conceived of training and the need for education, we turned it on its head a little bit, and it became a project that really was about increasing empathy and reducing stigma toward people who experience substance use disorder. And also created a a better understanding of the factors that contribute to substance use disorder and mobilizing a community response. So the project initially conceived of was 6 months, and it turned into about a 9-month project, which is started in January 2020 and complete in November 2021. Okay, so project objectives. The purpose of the research was to engage local communities to increase empathy and reduce stigma towards people who experience substance use disorder. The project originated in Edmonton, where I live, but was designed to reach all small communities and metropolitan areas in Alberta, a province in Canada. In Alberta, for some context, like British Columbia, we have a disproportionate number of deaths due to substance use disorder, and more specifically around opioid use disorder. There have been an 88% increase in deaths and a 27% increase in hospitalizations since the pandemic related to substance use disorder. Secondly, the project was to provide information resources and support for understanding addiction and substance use disorder, looking at most publicly available instructions and educational materials. In Canada, we found that often resources have been historically designed by healthcare professionals for healthcare professionals, excluding various different user audiences. Third, the purpose of the project was to connect with different sectors of the community to mobilize a community response. While the project was originally designed to promote awareness and empathy, communities are now able to have discussions with other community members about the next steps in managing substance use disorder. And fourth, it was really designed to set a direction and a plan for the project that had a strong commitment to responsiveness and a diversity and inclusion mindset, since we were working with many different populations of people and their families related to this issue. Okay, so this is the process that we followed throughout the project. It was not linear at all, and we revised and reworked many times, partly due to the pandemic, but partly due to the populations that we were working with. So first we just learned and discovered about the audience through a series of interviews. Second, we defined the research scope and the problem definition by analyzing some of the literature, which was interestingly about graphic communication and comics. Third, we defined the design criteria and worked with our population to in various co-design workshops. Next, we prototyped the concept through that co-design process again. And we're really in the last stage of the project now, where the design iterations and changes are being tested. And there's a comprehensive survey that goes out to any host community that has the that hosts the exhibition. So I'm just going to go into these a little bit. So the first thing that we did, not knowing anything about the work or the population that we were working with, is designed a set of interviews so that we could learn about the audience. So what you're looking at are sketches. On the next slide, I have final videos of 3 videos that we put together to try to understand the experience of having substance use disorder. So we organized a series of semi-structured qualitative interviews over the phone with women in Alberta who had lived experience of substance abuse. We recorded the 1-hour interviews and then transcribed them, and then did a little bit of thematic analysis, and came up with a series of videos that described some of the challenges that these women were facing. One of the videos deals with their experience around substance use and trauma-informed trauma. One deals with stigma, and then the other deals with the motivation to change and to want to help, even though you're sometimes not able to if you've got a substance use disorder. So these storyboarding and developing these videos were really key into understanding that it was important to tell a narrative and show and understand the voice of the people behind these stories. So not just about what we thought that the project was going to be about, data and analysis and showing a lot of educational materials and testing them. It was really a lot about understanding and acknowledging these stories. So next we moved into sort of the research scope and problem definition. We used a participatory design method that has played a large, increasingly important role in engaging communication in health system change, particularly in supporting collective responses to health needs with marginalized and equity-seeking groups. We knew that co-design and the method of using co-design was going to be very important in engaging marginalized groups and communities that had lived experience and typically use non-traditional knowledge forms like narrative to tell a story. Co-design was also important for community-based decision-making and shared ownership in the project and in the development and implementation of health system solutions. So what we originally conceived to be a project where we met with groups in person to review design concepts turned into a project that was online, where we had to pivot all of the materials that we used. So what you're seeing here is some of the we developed a toolkit of like a material toolkit that we sent out to participants prior to each workshop. We had 6 workshops. And each workshop we developed a toolkit of, cards or material things that the participants could work with so that we could have a conversation about, what needed to go into this exhibition. In some cases, we mailed the toolkit to participants so that they'd have it in their hands. But what we really found was that participants struggled with technology. And so each time we'd conceive of a workshop, our methods in terms of engaging the population would change. That was partly due to the pandemic, but also just in working with a population that didn't have as much access to technology and digital tools. We really had to sort of rework what those activities were. So here you're seeing an example of a Zoom call where we've got a participant on the phone, but then also we're working through several different activities in this workshop. What we realized was that in some early survey work was that participants that were surveyed knew how to respond in an overdose. They knew how to, what they really, really wanted us to tell in the story of this design exhibition was the importance of connection. They wanted us to explore the idea of stigma in substance use. And then they really wanted to promote proper use of language and supports related to addiction and substance use disorder. It was very important that the stories of the participants were acknowledged, as well as providing information and educational materials. So we invited participants to share their thoughts and concerns about substance use disorder and supports. And then we had a variety of activities where we asked participants to walk through a journey and identify barriers, challenges, and motivations that they might encounter along the way. The really interesting part about the literature review that we did at the same time as the co-design workshops were, we began to look into this technique called graphic pathologies or graphic medicine. And originally, I think this hadn't been a method that we would conceive of using, but this method was really mentioned by one of the participants in the workshops as a technique to tell a story. So this, we looked into graphic medicine. The term describes the use of comics in theory and practice of medicine and health communication. So it was originally coined by a doctor in 2007 to explore the use of comics as a medical communication tool. Within graphic communication, such as the use of comics, there are different ways to represent symptoms and experience of illness, health, and healing, inclusive of the perspectives of healthcare professionals and or patients. So, so we were finding that graphic medicine or graphic pathologies were used in a couple of different ways in the literature. So we found that they were often used as narratives produced by patients, caregivers, and our healthcare workers with lived experience related to illness and healing, because they give context and insight into holistic experience of health and illness, diagnosis and treatment. And they were also used, so they were used first as autobiographies or memoirs, and secondly as educational materials, because they could present graphically factual information, through an accessible means. So I've got a couple of examples here. This is called The Crisis in Our Neighborhood. This is a journal article published in the form of a comic that provides information about the opioid crisis in narrative form. It includes and illustrates evidence-based harm reduction strategies. It also represents the perspective of patients. So how does it do it? It's sequential, meaning things happen in order and develop over time. And some of the benefits are that it conveys meaning through the synthesis of text and image, and then it combines language and techniques of literature, film, comics, and books. You can see in the next, or you can see through this, that you see in the first panel the doctor's very neutral face and the patient's closed body language contrasted with the last frame where they're actually having a conversation and things are more open. The patient's posture is open and brighter. And so we looked at these examples of graphic medicine to see if we could, it would inform our work. So here's just an example of how you can see the disconnection in the first frame, but then, and then a connection that's formed as the doctor and the patient come together in the last frame. We looked at other examples as well, and there's quite a body of work that uses this form of communication. It benefits healthcare workers and practitioners because it provides access to patient perspectives and experiences. It uses empathy building tools and lifelong, learning, as in these can be translated through series it also benefits patients. Because it communicates and normalizes experiences, thoughts, and feelings that may come up through a process or diagnosis. Can help set expectations for treatment plans or care. It also just encourages active reading at one's own pace. So it can be helpful for readers with limited time and or low literacy. And so when we kind of dove into these examples, we realized that this might not be a bad way to take the work. So this is harm reduction comic. It was an educational and community outreach resource written and drawn collaboratively by people who use drugs living in San Francisco. It compares harm reduction strategies to punitive measures, and it allows people to see, sort of different combinations and outcomes of working together with health practitioners. Whereas this one from 2014 is also another health communication tool. it aims to show the personal, social, economic, political aspects of addiction and the opioid crisis. So from this research and early literature review, we had determined in addition to the interviews that we would be using storytelling or narrative or graphic medicine in order to mobilize the stories that we had heard in the initial interviews and co-design workshops. So the next phase of the work really involved determining how to mobilize the information to a wider audience. We looked at sort of movable units that had the ability to allow viewers to connect with the information that we were providing. And also discuss the importance of stigma, the stories of the perspectives of people with lived experience, and the language and supports related to substance use disorder, which was key to the participants. So it was a really complex project in that we had these sort of layers of information that had to be designed within the panels. So we prototyped the stories. We determined that each story should be told from the perspective of one participant, but that we also use audio and visuals that link the information and facts about substance use disorder to the participants. Okay, so our first set of iterations after we had the co-design sessions, we took the stories of the people with lived experience and we turned them into journeys, or we tried to figure out how we could incorporate the journeys that they had as part of their experience. So on the left-hand side, you see a prototype of one of the storytellers that was narrated by one person. So it chronicles the beginning of substance use disorder till his life now, including all the ups and downs, and interspersed with some content about adverse childhood experiences, trauma, as well as intergenerational trauma, which we saw throughout the stories. On the right-hand side, you can see how we carried through that system or design to replicate it for each of the other participants with lived experience. So we developed a bit of a system, I guess. When we took it to the participants, they said they didn't like it, and they wanted more evidence of story. So this was great feedback. When we looked back at when we looked back at that graphic medicine or graphic communication or graphic pathology, one of the storytellers had developed these panels, these large narrative comics. So we asked for feedback on the panels, and they said, well, we designed these journeys with you. Why don't we incorporate them into the panel design? And so what we ended up doing was taking the narrative, the graphic comics here, and incorporating them into the panel design. So you can see here, these are comics that were designed by each person and were then incorporated into the system of movable panels, which I showed in the previous slide. So moving on, we integrated the large narrative panels and the comics into the panels, and this became the basis of the traveling exhibition. So the first place that the exhibition was hosted was the Edmonton Public Library. People were allowed came and navigated the space. Each storyteller had a panel, as well as there was other information about intergenerational trauma, the residential school system, trauma-informed practice, and some of the other issues around opioids and the opioid crisis. So here you can see the layout of the panels. We also had as part of the project, we had naloxone training, naloxone kit training, which you can see in the bottom, where we had, which is an opioid antidote, for those of you who don't know. So we had training, and we had nurses and practitioners that would come and work with community members who were at the exhibit, as well as give out naloxone kits. Here's another picture of the panels. And then we invited some feedback on the right, so that this project is still touring. And so we've got a feedback mechanism as well as a survey that will help to determine how the project gets translated in its next phase. So the graphics in the large movable exhibit has now been shown in over 20 venues from July 30th to from June 30th of last year to July 1st of this year. But of course, the project was not without its challenges. Here's some of the, it got a ton of media attention, and it's still traveling. So here are some of the different places where the exhibit was hosted, as well as the naloxone training, as well as the educational materials and the toolkit that we developed for the project. So how am I doing for time?
You're doing fine. You're about halfway through our hour, so just want to leave 20 minutes or so if we can. If you can wrap up in 10 minutes or something like
Sure.
that.
Yeah, easy. Right. So key challenges to this project. So this project required a regular commitment of time and real-time digital prototyping skills when we worked with people that had lived experience. And so, because of the pandemic, and in the workshops, we realized that we had to transition all of our team activities from in-person to online. So we were having to pivot all the time to try to transition the working methods that we were using, as we realized that not everyone had the same technological capabilities or digital tools. Most people were able to join from their phone, but that meant that they couldn't actually edit or send files electronically or work on a Miro board with us. They were able to contribute by speaking and allowing us to hear their experiences, but it was a real challenge sometimes to get creative feedback, I guess, or the materiality of the project. We always wondered if we lost a bit. Managing multiple stakeholders, groups, and competing interests. The workshops, we tried to keep participants together as a team, but often the populations that we were working with were available at different times due to childcare constraints. So we tried to combine in those 6 workshops healthcare practitioners with people with lived experience, with the project team, with a municipality, for example, and we often had issues getting people together, and many of the workshops that we did were after hours, which was a challenge for the project team. Access to requirements and feedback through small, directly engaged stakeholder organizations and providers. It was challenging to find time during a workday, and many of our meetings were in the evening, as I just mentioned, getting late into the night when people could meet. Prototyping and feedback was also a little bit of a challenge. So through the lens of co-design and of diversity and inclusion perspective, it was tempting to go just to the project team, but in truly in a co-design working methodology, you would meet and get feedback from the entire team together in one space. And this was also a challenge for us. And then just different digital tools, technology, and formats. Most people, as I said, were joining on their phone, but didn't have access to the computer. So sometimes those co-design sessions were a bit tricky. But we did learn quite a bit. So because this was a project that happened during the pandemic, social distancing laws, of course, under the pandemic conditions, imposed restrictions on co-design formats, specifically limiting or even eliminating face-to-face in-person formats. So we constantly had to revise and rework our pandemic protocols for working, receiving feedback, and for meeting with our group. At the end of the project, though, we did have an opportunity to walk through the space with participants and attach sticky notes to these huge panels, where we got instant live feedback in that way. I wouldn't say that the timeline was really impacted, but we always wondered if the materiality of those co-design sessions and creativity was impacted by the fact that we had to do a lot of the work online. Secondly, digital tools and formats. So from an equity, diversity, and inclusion perspective, this changed the included versus excluded demographic, opening participation for some. So some people, had, just by the nature of being able to meet online, opened up their ability to meet and to have opportunities to meet because they could join from their phone. But then it also excluded or restricted participation for others, such as people with limited digital resources. Third, I think, the remote and online forms of co-design place barriers in the way that some of these forms of communication were handled, potentially affecting the relationships and trust, sharing of experiences, ideation, creativity, etc. So, sometimes it's easier, I've found, in co-design work to be in person, in front of people, working on a table, where you can have that conversation, and you lose a bit of trust, especially when working with marginalized populations. You have to create that trust, I guess. It takes longer to create trust before you work together, and that's one of the challenges of this project was. We always met together, and at the beginning of the meeting, we'd have one of the participants do a smudge, where she burned sage, which was a nice, way of coming together. And at the end, there was like the equivalent of a prayer. And so that was a way to sort of bring the group together and acknowledge that we were all in the same space, working on the same type of material together, and obviously not always possible. And then the last thing, material and creativity. We had to constantly think about how to create, and think about adaptations to the toolkits that we provided participants, because of being online. So there was this constant reworking and rethinking of, well, what are we trying to get from the first co-design workshop? What are we trying to get from the second? How are we going to do that online? Who we have access to? Do we need to create activities where we're doing a card sorting? Can we even do that? Can we do a card sort if, by getting people to take pictures on their phone and send it back to us? Like, it was quite challenging to figure out how activities could actually be done together, and sort of coming up with a way to create a tangible material that people could respond to. And then, of course, wondering if that material that you used would have the same effects as if you had done it in person. So what I'll do is, maybe the project website has a really great video, and I can send videos of those smaller the experience stigma videos that we created, so I can send those out to anyone. But this project website has some really good has a great video that kind of chronicles the whole project, and that's here. Oh, next slide. Thanks.
Hey, Gillian, thank you very much. Thank you.
Should I stop sharing?
Yes, unless anybody wants to go back to any slides, but why don't you stop sharing?
Okay.
And anybody got any questions, please raise their hand. Petra.
Hi, everyone. Firstly, thank you so much for organizing this, and thank you, Gillian, for sharing. I apologize, I'm on a street, so I hope that there's not too much noise. Yeah, so I work on taboo topics, I specialize in taboo topics, and I was very curious. Apologies if this was already shared in the presentation, but since I know that there's not a lot of information out there, I was wondering what are the materials that you have used in the project to ensure that when it comes to approaching participants, what are the tools or theories that you have used in the creation of materials for research? And I had a second question, but now I kind of forgot it. But yeah, I also wanted to say congratulations for the project. It really looks amazing, and also for it to have received such traction to go in over 20 places. That's amazing. Yeah, thank you.
Thank you. So frameworks, we used an EDI framework. So in working specifically with marginalized groups, we also use.
Sorry, can you explain that, please, Gillian?
Oh, yeah. So a lot of the work that I'm doing is in co-design, and it breaks down a framework for working with using equity, diversity, and inclusion across different populations. And so we used that type of framework, as well as a trauma-informed, practice-based framework, which I could actually send to anyone who's interested in working with these groups. The other thing that we made sure that we did was tried to stay true to co-design methodologies and working philosophies when, for example, we got feedback or we presented information to a group. Rather than presenting, we always invited feedback, and originally that's not the way that we thought we would be working, but I guess those are the sort of the three main frameworks for working that we used.
Okay, Andrew, you have a question. Hi there. Andrew, you got your hand up. Andrew Barker. Okay. Come back to Andrew. Anybody else got a question? Andrew. Yes. He was muted. Andrew,
Petra says, are there any papers published on the project?
Oh, yeah. Yeah.
So Petra, not yet. I'm working on one at the moment.
Andrew, can you contact us? No. Veronica, you have a question. We'll come back to you, Andrew, if you can hear us.
Yes. I would never have thought that you would use or that you could use aspects of spirituality to bring a group together. It would never have occurred to me in any user studies I've done so far. I find that really interesting. How do you come to employ that?
Yeah, that is, and I hadn't ever really conceived of that being important either until we started working with this population. But I think it was just a way to bring everyone together in a common meeting space, and we had many Indigenous participants, and that was one of the ways that Indigenous people come together in a common place, and sort of almost I guess they come together, and everyone works from the same field, and so that it just became a way to incorporate sort of equity, diversity, and inclusion into our work. The other thing that I've heard of people doing sort of in co-design work is having a meal together, or, establishing sort of like commonality that way. And so, yeah, it worked out really well. And one of the participants in the session led that smudge and prayer each time we met.
Okay. Thank you. Yeah.
Andrew's put his question on chat. He couldn't unmute. He's saying, I was wondering how you dealt with the challenges of the team working on such tough content. You said that you trauma-informed practice, but what did this actually mean for your project?
Yeah, that's a good question. So we had nurses and we had psychologists and on the team, and we made sure that they were part of the co-design sessions. And some of the content was actually pretty hard to listen to, but in the end, we found that when everybody was sort of on the same page, people actually really wanted us to acknowledge their stories rather than just give information. And it was a lot about acknowledgement and sort of telling the stories the way they wanted them to be told, I guess.
Saskia, you have a question.
Hi. Thank you for your presentation, Gillian. It was really interesting to learn more about this. I was wondering, why was the format of an exhibit chosen? Why not something else?
Yeah, I think probably because so many places in Alberta are struggling with how do we connect people. So part of the whole thing was about connecting people to these issues. And I mean, we had a website, we had toolkits, we had educational materials, but the team felt that it was important to immerse people in these, like create an immersive environment where they were surrounded by these stories. I guess and usually there's a lot of material out there related to, what to do in an emergency situation and how to deal with stigma in terms of pamphlets and, print and digital forms, but there isn't an immersive experience where you could really see and feel and hear the perspectives of these people.
Then I've got a related question, which is, I was interested in sort of to what extent the exhibition was co-designed in that you designed something that was quite designerly, quite clinical, very beautiful. And then you showed us these comic strips, which participants had done. And rather like that San Francisco example, they were much very raw and very emotional and graphic. What happened to those? Because when you then showed further slides of the exhibition, it looked a bit like the first one, which they didn't like. Is it that you didn't really show?
Oh,
I saw a glimpse of their comic strips somewhere in the background. They were there, were they?
They were. I didn't mean to not show them. They're very front and center in the panels, actually, because we recognized that it was just too clinical and it was, sort of designerly and didn't respect the content from those original journeys that the storytellers showed. So we also incorporated audio so that we could hear, you could hear the experience of the storytellers. But yes, they were actually quite front and center in the panels.
I have a related question about language, because the concern number 3 in the initial research was about the use of language. And I think that you had an example, something like addiction versus SUD.
Yeah.
So is SUD designed to, does that replace the word addiction as a non-pejorative, way of describing the condition without stigma? Is that what it is? What's going on there? Because then in the newspaper reports, every one of them used the word addiction.
Well, so it's interesting because the participants themselves used the word addiction because that's what they knew and understood, and all of the healthcare professionals would say substance use disorder. So substance use disorder is a way of including non-stigmatizing language for, it's one of the ways that we included, sort of that, and you could say we used an anti-stigmatizing language framework, I guess, and that's one of the examples. But often you find that people with lived experience are okay with addiction, with overdose, instead of the word poisoning, for example. So it's, and I'm not sure it's actually really ever resolved. That would be another framework that we use, though, anti-stigmatizing language. So, to saying poisoning versus overdose, saying substance use versus addiction.
But you're saying that the people themselves, participants, were owning they were kind of owning that word, weren't they?
Yeah. Oh, yeah.
Was it that they just didn't know another word?
No, I think they were comfortable with that word. I think they're familiar with that word, and I think they were. It was. We didn't really ever. I don't know if it's ever really resolved.
Yeah. I mean, I suppose the stigma.
I'd be curious to hear from other people about what they think related to language.
Anyone, put your hand up. Another angle on what you did was it was an exhibition, but of course you developed it during lockdown and described the problem of trying to work together online and not in the room. Where you could experience the smudge together and smell the burning sage. That's amazing. And so that it is interesting, isn't it, that you went for an environment where you could have the experts, the nurses, the demonstrations going on at the same time. It wasn't just stuff you had to read on the wall. So I'm trying to think of the timing. You developed all that during lockdown when you couldn't do that, but afterwards you.
Right. So we developed it all during lockdown, and weren't really sure what was going to happen, but we knew that we were opening the exhibition in early November, I believe, which we weren't even sure that we were going to be able to have an exhibition. So we essentially had developed a lot of work that we thought we might have to transition to an online space. And that was one of the discussions that we had at the beginning with the project team as well. If we can't do this in person, will we transition and do an exhibit online, or sort of have it hosted on a website? And everyone felt like that these stories were worth having, being immersed in, and it wouldn't have the same impact if it was online. And I think I agree that it was much more impactful to have it in person. But people were wearing masks when we were restricted in terms of how many people could come into the space. But the opening night had about 500 people that came to that first, and we've had, thousands of survey feedback. So we know it's traveled a lot, and I don't think it would be as effective online, but I mean, it was certainly an option that we discussed.
No, I think it's lovely you use the word materiality as well. I think, we've got used to everything going digital and losing smell and feel and so on.
Yeah.
Robert, you've got your hand up.
Yeah, I was just kind of wondering, everything happened during the pandemic, and you had to kind of shift and do things kind of ad hoc. Any thought to bringing some of the groups back together now that you can all get together and pandemic's over, and see if, sort of as a follow-up, to see if that would have made any real difference in what you did?
Yeah, I think that's a great question. That's what we're planning. So that's the next stage of the project, is to bring everyone back together and look at the survey that has been filled out as it has traveled to these small communities. So we're bringing everyone back, and we're going to do a phase, I guess you could call it phase 2 of, maybe it's a different exhibition, but it will be a continuation of the work that's, maybe that's not designed to promote awareness as much, but a little bit of behavior change as well. So I think that's what we can do in the next iteration. And we are still in contact with all of these participants. In fact, they became really involved in the work, more so like it started from the design, but now they're actually going out and speaking in front of the exhibition. And so they're like spokesmodels for the project, which is great. They really sort of embraced the idea of being able just to tell their stories. So yeah, that's sort of phase 2, I think, for this project.
Saskia again. Hi.
Megan. So the stories are all from people who've had substance use disorder. Did it make them likely to maybe relapse into that, or did they experience it in a different way where actually it made them feel stronger in distancing themselves from that, or maybe accepting that they'd had that experience?
They were, yeah. So I think all of them were involved in the project because they had been involved in or had a substance use disorder, but I think they were far enough from it that there was always the possibility of relapse, of course, but they were just so empowered that they were able to talk about their experience, and that someone was willing to acknowledge the hardship, I think. They were quite open and willing to share. But I guess it's always a risk.
Veronica.
Yes, you said one of the main reasons for doing this was to raise awareness about the condition and about communicate the position of people with SUD. Do you have any, or are there plans to continue once the exhibition stops traveling, which generates a lot of communication, but would that just be the baseboard for longer term communication?
Right. Yeah. So this has been a research area of mine. It's working with population